So today we're going to do some lecturing on the spleen after going through some of the notes provided for you guys. I wanted to go through and just do a little bit of elaboration. First things first, let's talk about what do we know about the spleen. Is it intraperitoneal? Is it retroperitoneal? What are its functions? How does it look sonographically? What are its normal sizes, its normal variants, its abnormal variants, and some things that it's more predisposition to being the particular organ that it is. So first things first, we'll start with the location of the spleen. So we know that the spleen is an intraperitoneal organ, which means it's covered predominantly by the peritoneum with the exception of the hilum, which is going to be right over here. And that's where the vessels enter and exit the actual spleen itself. So it's intraperitoneal, if we remember that glossy acronym. It's also the largest organ in the lymphatic system. With that, it's also the #1 traumatized organ in the body. So with it, it's encapsulated, and it's composed predominantly of red and white pulp. Now that white pulp is composed of a form of a white blood cell that are known as lymphocytes, and then the red pulp is composed predominantly of connective tissue cords. Not in the notes, but another name for those cords are cords of Billroth. So as we move through again, it lies in the left upper quadrant of the body. So this is my right, but the patient's left. So if we imagine our patients, we're going to lie in that left upper quadrant, a little more posterior in the body. And again, that particular area is also known as the left hypochondrium. So left upper quadrant, left hypochondrium, and again, it's peritoneal organ. It's an intraperitoneal organ with the exception of the hilum. So the hilum isn't going to be covered by that peritoneum. So some other things as far as relationships to the spleen. So if we think of the actual body and the fundus of the stomach, and we go through, the stomach essentially lies anterior. So the spleen is going to be posterior or behind and lateral to the body and fundus of the stomach. So body and fundus, and the spleen is going to be posterior, so behind, and lateral. And again, remember that lateral means that it's going to be towards the outside of the body, whereas the actual stomach is going to lie anterior to it, just in front of it, and then more medial in the body. So more along the lines of the center portion of the body. It's going to be closer to our center line. It's also posterior lateral to the pancreas. So we have our pancreas here. We did a couple lectures on it, but here you can kind of see how the pancreas goes through, and the unstained process is posterior, and then it wraps around, and then the tail starts to course posteriorly towards the hilum of the spleen. So again, the spleen is going to be posterior lateral to the tail of the pancreas. So here's our tail of the pancreas, and it's just behind and lateral. So again, posterior to the pancreas tail and lateral to the pancreas tail. Left kidney, we have sitting right in here. So we can see that the left kidney is going to actually go through, and it's going to be a little bit inferior and medial in the body. So the kidney is going to be a little bit below the spleen and a little bit more medial in the body. And again, we know that kidney is retroperitoneal, but again, it's going to lie more medial in the body and a little bit lower than our spleen. So our spleen's going to be up just a little bit higher. The diaphragm is going to be anterior, so it's going to just go through and lie slightly anterior. It's going to wrap around laterally, and it's going to sit superiorly. So we know again that diaphragm is going to be the most superior part of the abdomen. And then the stomach and the lesser sac are anterior. So again, if we put that stomach right in here, stomach is going to be anterior. And that lesser sac, who remembers where the lesser sac is going to be located? I'll give you a second to think about it. So we have our greater sac and our lesser sac. Where's that lesser sac located? So the lesser sac is going to be anterior to the pancreas, but posterior to the stomach. So again, it's going to lie just between the pancreas and the stomach. That's where our lesser sac is going to be located. So again, the stomach and the lesser sac will be anterior to the spleen. So sonographically, I noticed there were no slides of the sonographic appearance of the spleen. So how do we think the spleen typically looks on an ultrasound? So it's going to be very comparable to the liver, which we don't have in here right now, but it's going to be very comparable to the echo texture of the liver. It's going to be very homogeneous, low-level gray echoes. And then if we compare it, our organ that we use for comparison for the spleen is going to be the left kidney. We know the right kidney we use for the comparison of the liver. So on the left side, we're going to be using the left kidney to compare the echogenicity of the spleen. So how would the spleen from what you know at this point, how would the spleen compare in echogenicity to the left kidney? And again, I'll give you a second to think about it. So the spleen is going to be very isoechoic to this left kidney, or it may be slightly brighter or hyperechoic on an ultrasound image. And both of those are considered normal for a slightly hyperechoic or isoechoic to this left kidney. With size, it's typically going to measure 12 to 13 centimeters in its actual overall length. And if you look at it, the shape of it, it typically looks like a mushroom or a baseball glove, and it's about the size of a balled up fist in the human body. So if you ball up your fist, that's roughly the size of the spleen, but it's going to be up to 13 centimeters in length. Anything past 13 centimeters in length is abnormal. It's enlarged. Now let's talk about the vasculature. We talked about the hilum where the vessels enter and exit. So I'm going to take the pancreas off for demonstration purposes. So we don't have the portal system in this. It's actually located on the back of the spleen, or on the back of the pancreas. So I'm just going to go through and discuss how it's going to course in the body. So I'm going to lay it right down here on the floor. So here we have our celiac axis. So we're going to talk about the splenic artery first. So we have our celiac axis. Now, the branch of the splenic artery happens from that celiac axis. We have the hepatic artery, then we have our left gastric, which we don't typically image, and then at the, again, superior border of the pancreas, that top border of the pancreas, we're going to see that splenic artery. That splenic artery is going to course from medial to lateral, where it's going to branch off into about 5 different portions before it enters the 5 different branches before it enters the hilum of the spleen. And now coming out of the spleen, traveling from lateral to medial, will be our splenic vein. And again, you can kind of see it here on the back, so I'll just flip this over. So this is our splenic vein. And it's gonna go through and it's gonna course until it meets with what vessel to form what. So we have a couple different vessels. We have the IMV that will come off and course essentially vertically in the body. And we don't typically image that, but what is the main vessel that splenic vein converges with to form? So again, that splenic vein is going to course with the SMV, and they're going to merge together to form the portal splenic confluence before forming that main portal vein, which would go into the liver. So again, I'm going to flip this over and show how it would basically lie in the body. I'm not going to go through, and we'll do a little re-hookup. So again, if we go through and we look at the top aspect of this, we have our splenic artery that branches off the celiac axis and travels to the hilum of the spleen, and then we have our splenic vein, which goes through and it has a couple different branches that converge together. It's going to bypass that IMV, which will be located on the left side of the body, before converging with the SMV, which again, it's going to be behind this pancreas neck. So it's posterior to the pancreas neck, and you can actually see a little portion of it coming out here because it's anterior to that unsnate process. So that SMV is posterior to the neck and anterior to the unsnate process, which is located behind the duodenum right here. So again, that splenic vein is going to course from lateral to medial, where it forms with the merges with the SMV to form the portal splenic confluence right before it travels into the liver, which we don't have in here, just so you guys can see everything a little bit better. There's a couple different pictures and diagrams. I would definitely recommend looking at those for labeling purposes later on. So functions of the spleen. So now we will go over a couple different functions of the spleen. The spleen is part of our lymphatic system. It's again, it's going to be the biggest organ in the lymphatic system. It removes and destroys microorganisms and damaged or old red blood cells by phagocytosis. And what that basically means is that those red blood cells are engulfed and then destroyed and then removed. It also acts as a blood reservoir, so it's again, it's going to do phagocytosis, and then it acts as a blood reservoir. Here it's going to store red blood cells, white blood cells, platelets. It does, again, recycle those red blood cells, but this is where a lot of those blood cells are stored. So let's say you get an infection or you get sick, the spleen will go through and it will release a lot of those white blood cells to fight off an infection. Again, we know that red blood cell and platelet destruction is known as phagocytosis, so that's a function of the spleen, a blood reservoir where it's going to go through and store those blood cells. And then hematopoiesis, so it actually will go through, so let's say if like bone marrow can no longer, for whatever reason, produce red blood cells, the spleen will actually take over. Its function in the fetus is to do hematopoiesis until that bone marrow is formed. Usually around 5 months is when the bone marrow will take over. But during that process, during that time up until that fetus is about 5 months old, the hematopoiesis occurs to where the spleen will make those red blood cells. And again, if for some reason an adult their bone marrow is no longer producing those red and white blood cells, it will take over and perform hematopoiesis on a person who cannot do it for whatever reason with their bone marrow. And then the white blood cells, again, they're going to be the purpose of white blood cells. We check those, we run those frequently as lab values. Those are to check for infection. So high white blood cell count, usually again, that spleen is going to go through and release those lymphocytes. Those are actually special little white blood cells that go through and fight that infection. So lastly, I want to talk about some normal variants. So we have an accessory spleen. That's a big one we see, probably the most common out of everything. So with an accessory spleen, typically you'll see it right around the hilum. It'll be like a little ball. You may see multiples, but typically they measure under 2 centimeters in their size, overall size. They're very isoechoic to the normal splenic tissue. They even have their own little vascular supply. But again, there's a couple pictures in your PowerPoints, but they're very, very small little ball shapes typically that are under 2 centimeters. Again, normally they're under 2 centimeters. They're isoechoic, and they will have their own vascular supply. And again, you will see them typically near the hilum, again, measuring under those 2 centimeters. And another variant or normal variant is asplenia, which means either the person was born without a spleen, or let's say they've had a splenectomy. So one is congenital, one is acquired. An acquired asplenia situation would be where a person has a splenectomy. However, asplenia also means that they can possibly have a spleen, but it may be very underdeveloped and non-functioning. So just because they have or have been diagnosed with asplenia doesn't necessarily mean you won't see the spleen. It just may be very, very tiny and not function properly. Also with asplenia, it may be associated with congenital heart defects. Again, it may be an isolated variant where the person is just born without a spleen and nothing else is particularly wrong, or it may be associated with congenital defects of the heart. Also, when we have asplenia, we also have its opposite, polysplenia. And what polysplenia is, if we think of the word poly, what does poly mean in the medical setting? Multiples or more than. So polysplenia, multiple small spleens. So again, they're going to be multiple spleens. They're typically going to be smaller than a normal spleen, and they might be over on the left side. You may see some over by the liver, just multiple little spleens. And again, this also can be an isolated incident, but with this one, it's usually associated with some sort of anomaly. So polysplenia is more likely to be associated with anomalies. And then another big one we see a lot, the most common abnormality, I want to call it abnormality because it's not really a normal variant, is splenomegaly. And it's typically associated with other disease processes up to 13 centimeters. So what are some disease processes that we've talked about that may enlarge that spleen? Think of all our other systems and how they work together. So we've recently talked about the portal system, so we'll address that, but portal hypertension. So let's say a person has a very cirrhosed liver and essentially causes backup in the portal system. Well, we know that the splenic vein travels and meets the superior mesenteric vein, and then they course into the liver. Well, if that liver can no longer take that blood in or it's slowed down, it's going to start backing up into other organs, i.e. the spleen, because this is its path of least resistance. So it's going to start backing up into the spleen over here, causing splenomegaly. Mononucleosis, again, those white blood cells are there and they go through and they engulf, especially some particular types of diseases, the pathology from some diseases. So mono is a big one with the spleen. So a spleen may be enlarged if a person has mono, or actually has ever had a history of mono. There are cases where if somebody has a history of mono, the spleen just stays enlarged. So again, that enlarged is going to be anything over 13 centimeters. Some other things that may cause it: leukemia, really any sort of like hematopoietic sort of dysfunction. Sickle cell anemia, those things of that nature. But again, a big one that we just discussed was the portal system. So portal hypertension is going to be something that we see and we go through. It's important to know that because if a person, let's say, does have cirrhosis, you do want to make sure that you're going through and checking the spleen to make sure that disease process of the liver hasn't started to affect the spleen. With that, with splenomegaly, what is a complication? Something that we think of when we think of the spleen is we think of splenomegaly, the spleen gets enlarged. What's the problem behind that? I'll give you a second to think about it. So we talked about the spleen and how it's the #1 most injured organ. When that organ becomes enlarged or inflamed, it's got a higher chance of becoming ruptured. So that's a big thing we want to think about with that, is that increasing the size of the spleen will actually increase its risk of rupture. And then our final one is called splenic ptosis, PTOSIS for those of you who aren't really sure how to spell that. It's also known as wandering spleen. So what that basically is where the ligaments of the spleen that hold it in place, they either are weakened or they become lost. And essentially what happens is that spleen doesn't stay anchored into one place. It just goes wherever it needs to go, wanders around the abdomen cavity. So again, it's usually in that left upper quadrant, but with wandering spleen, you don't know where it's going to be, and it may vary in its position with each scan, just because it doesn't have anything anchoring into its particular location where it's quote unquote supposed to be. Our last couple slides discuss things such as metastases, but we're going to wait until we get into the abdomen lecture for that. So again, just a little review. Intraperitoneal, left upper quadrant, left hypochondrium, splenic vein, splenic artery at the hilum that is not covered by that peritoneum. They travel, and again, the splenic vein will course until it meets with the SMV to become the portal splenic confluence, and that splenic artery is a branch off the celiac axis. It's roughly the size of a fist, up to 13 centimeters in length. Anything past that is too big. Some normal variants are going to be the accessory spleen, wandering spleen, asplenia, polysplenia, and splenomegaly. Those are things that you may typically see within that spleen. And finally, as it appears on ultrasound, it's going to be homogeneous, low-level grays, slightly hyperechoic to the left kidney, or isoechoic to that left kidney. So I hope this helped, and again, it lies just posterior to almost everything. So posterior lateral, it's a very lateral organ. So I hope this helps the overall the view of it and how things work and some normals and abnormals of the spleen.